So, good afternoon, everyone. Once again, I would like to thank Dr. Ashok Sharma sir and Rajan for giving me this opportunity. So, I'll try to be brief. My topic is Tenon Patch Graft, a stitch in time. So, as we all know, corneal perforation, it is an ocular emergency. For small perforation less than 2 to 3 mm, they may seal spontaneously or with tissue adhesive like cyanoacrylate glue. And that's what we use as temporary procedure day in and day out. Also, infection control, lubrication, and cycloplegics, they are quite important in the management. Prompt diagnosis and intervention are crucial. However, for larger or leaking perforation, surgical repair tools such as Tenon Patch Graft or corneal transplantation is needed. So, less than 1 mm, you can patch or bandage. Slightly larger, you can do glue and BCL. 3 to 5 mm is basically you can do a patch graft, and more than 5 mm you have to do a therapeutic PKP. So, why I chose this? Because not everybody has the the corneal tissue available, and then you have to go with the certification, HOTA rules, organ transplantation rule and stuff. But Tenon capsule is always available in the eye in the same patient. As we all know, Tenon's capsule is a fibrous membrane that envelops the eyeball from the optic nerve to the limbus, separating it from the surrounding orbital fat, lies between the conjunctiva and sclera. It is composed of dense connective tissue and contains fibroblast, collagen, and elastic tissue, and that's what exactly we need to close the perforation. So, Tenon's patch graft, it is glove sieving procedure, autologous, easily available, and you can use it from the same eye. You don't have to take it something from the other eye or other person. So, I'll just show some representative cases. 25-year-old male, history of trauma, vegetative matter injury, treated elsewhere, and had a corneal ulcer, then it perforated and referred to us for management of the corneal perforation. So this is how it looked like: 3.5 to 3 mm perforation, iris prolapse, flat AC. So since corneal tissue was not available with me at that time, otherwise I would have done a patch graft. So we planned to do a Tenon's patch graft to close the perforation. And so watertight. Gradually it integrates with the surrounding corneal tissue, and you can salvage the eye. So this is how the patient looked post-operatively and after suture removal. So case 2, sometimes even as a corneal surgeon we get these patients, 70-year-old male presented with complaint of foreign body sensation and pain in right eye, cystic bleb following trabeculectomy. So this is a overhanging bleb causing lot of discomfort to the patient. This is a ring of steel. So somehow last case is a case of phacoemulsification. The patient was sent to me by one of my high volume cataract surgeon colleague in a very panicky situation, 60-year-old male who had uneventful phaco, but at the end of the surgery, he had problem with the wound closure and persistent leakage from the side port incision. He tried to close the incision with sutures, but the wound would kept on gaping, and then the iris prolapsed. He cut out some of the iris, but eventually he couldn't close the wound. So in the afternoon, he sent it over to me, and this is how the patient looked like. Flat AC, iris, partial iris defect, where he had done the iridectomy or iris excision. He had applied a couple of sutures and some iris was hanging outside. So on slit lamp, there was circumferential band of thinning around here with a flat interior chamber. A perforation was seen at 12 o'clock, and pupil was peaked obviously because of the excision. The other eye, we had this findings, marked superior thinning and 18 diopter of against the rule astigmatism consistent with Terrien's marginal degeneration. So as cataract surgeons, sometimes we are too quick, and he missed it probably pre-operatively, or he thought he would get around, but this thinned area does not withstand, it does not have elasticity, so the side port gave him a lot of trouble. So the problem was, at that time I did not have any donor tissue, but otherwise this was a case for a patch graft. So here again I used a Tenon's patch. I plugged the perforation, then put a cyanoacrylate glue over it, and eventually on post-op day his AC, the globe integrity was restored, AC was deep, Tenon graft was intact, moderate AC reaction and irregular pupil obviously. So these are the shine plug images of the patient. The other treatment was just regular PKP. He was advised anterior lamellar keratoplasty after 6 months, but was lost to follow up. So take home message is Tenon's patch graft is a simple, cost effective and readily available biological tissue for ocular surface reconstruction, and can play a crucial role in small to medium perforation, especially when donor cornea is not available. It provides tectonic support, promote reepithelialization, and integrates well with the host tissue. And it can be combined with other adjunctive procedures like cyanoacrylate glue, amniotic membrane, or conjunctival flap for better outcomes. So it can be useful modality in resource limited setting, and then you don't have to be a cornea surgeon to do it, and you don't have to deal with the HOTA and Organ Transplant Act issues which we face in various eye banking and these regulations and so on. So thank you very much for your attention.
Thank you, Dr. Pawan.